Aibovan, and a very good evening to all our viewers here on TV1. I'm Dr. Dilshan Fernando, and this is your weekly dose of wellness here on Healthline. Today we are in conversation with Dr. Naomal Perera. He is a consultant oncological surgeon, and today we are going to be talking about the esophagus, or for the lay community who does not know this term, it's about your food pipe. So we are going to be talking about a condition or conditions that can give rise to a feeling of difficulty of swallowing, and some of these conditions are more sinister than the others. A very good evening to you, sir, and thank you once again for joining us here on Healthline.
Good evening.
So, firstly, sir, before we move into these conditions or diseases, what is this esophagus? If you can just elaborate, because we have many variety of viewers. We have medical students, we have young doctors, and we have the lay community watching as well. So, if you can just describe what this esophagus is.
Dilshan, as you correctly started by saying, it's a food pipe. It is a tube which connects your oral cavity with the stomach. It's a tube which goes through the chest, and it is found at the back of all the structures, including the heart. And it is starting from the pharynx. Now, when you consider the anatomy, we measure everything starting from the front teeth. So, if you say from front teeth up to the pharynx, that is the oral cavity with which it starts to divide into the airways in front and the food pipe at the back. It is a very complicated structure, the pharynx. At the end of the pharynx, the laryngeal part, it deviates to front, where it connects or continue as the trachea or the airways. The back part is become the food pipe. Now, this food pipe is the esophagus. Now, esophagus starts from actually from 15 centimeters from the front tooth. From there downwards, you get a muscular tube which goes through a small hole in the diaphragm, that is a muscular partition which divides the thorax from the abdomen, and soon after it goes through the diaphragm, it joins the stomach. And although this is a muscular tube, there are two important things when we consider the anatomy. One is, those are the two valves. You need two valves at the top and the bottom to control the food and push the food always downwards. The top one is just a sort of thickening of the circular muscles. It will just contract and hold it. It is not a very good valve, but fairly reasonably it controls the food getting reflux upwards. The bottom one, the muscular tube or the esophagus which comes down, it creates an obtuse angle with the stomach. So, it comes down like that and the stomach deviates to the side, and also with some muscle fibers arising from the diaphragm, it goes around the junction like a sling, and it controls the food getting regurgitated. This we call the lower esophageal sphincter, and we have the upper esophageal sphincter. In between that, the muscular tube is the esophagus.
So, for the intents and purposes of our discussion today, so it is a muscular tube which connects the oral cavity and the stomach, and it has some anatomical structural adaptations to keep the food from coming back up.
That's correct, yeah.
Right. So, now when we talk about the esophagus in our day to day practice, and you as an oncological surgeon, we see many people coming and telling us they have difficulty in swallowing. Now, we know that there are many causes for that, but today we will be focusing on the mechanical causes. So, if you can broadly talk about what these causes for difficulty in swallowing are.
Yeah, the difficulty in swallowing, that is very important to recognize this symptom, because say sudden onset may be lasting for about a day or two is not that significant. It could be caused by maybe some muscular spasms or something like that, but if it continues, then of course it is very, very significant that we investigate and see. Now, it is very easy to sort of remember how a mechanical cause can give rise to difficulty in swallowing. In medical terms, we call it as dysphagia. That is, if you consider the tube and if there is anything within the lumen, or the second, if it is found within the wall, and the third is outside the lumen or outside the tube which is pressing onto the tube. So, those are the three ways where we sort of easily classify the causes for dysphagia. The lumen, inside the lumen, usually or the common ones are foreign bodies. Say for elderly person, if there is a small denture which get dislodged and if accidentally swallowed, and as there are sort of wires associated with that can get stuck inside the esophagus and cause dysphagia. Or maybe in a small child it could be some sort of a seed or maybe some sort of a little object where it can get obstructed within the lumen. Those are not very common though, and it does not sort of go on forever, because within a couple of days or maybe maximum about a week or so, they will present to you at the clinic, and we can attend to it immediately and ease off the pain or the dysphagia. But if it is a lumen in the wall, the causes arising from the wall, those are very common, and those are chronic causes. In the sense, it goes on for many months and months, and sometimes even up to years. Unless if you investigate and attend to it very early, you will end up in so many other issues. The commonest one, although now it is sort of, we tend to sort of, because of lot of education, we see less and less. That is, those days it was the corrosive poisoning. Corrosive poisoning is the acetic acid. Now, acetic acid might wonder whether it is vinegar. It is not, I am not referring to vinegar. Acetic acid is found even in vinegar, but this acetic acid is the one which is used in the rubber industry. So, people, they tend to sort of swallow this either for suicidal purposes or accidentally, and this erode the esophagus, because although there are sort of protective layers in this esophagus, it can cause burning, and the burns, when it heals, it forms a scar, and these become strictures later on, and it becomes very, very tight contractures, and that will obstruct your food passage. But nowadays we do not see much, and the cancers have come up, and the cancer is the common cause that arises from the wall, which can give rise to dysphagia. And the third one is whether it is outside. I mean, anything from outside can press on this tube and cause dysphagia as well. And there are a lot of, we call it the mediastinum, that is the area in between the two lungs. There is a space. This space, we get a lot of structures going down up to sort of mid thorax. You get the airway, the trachea coming and deviating and going towards the lungs. Then you get the main artery, that is the aorta, that is which pumps the blood out from the heart. That goes down, and there are the various other veins and structures which comes to the heart. With that, you get the esophagus, and any nodes within that area, lymph nodes, if it gets enlarged like in lymphomas, can press on the esophagus. And sometimes it does not sort of cause severe dysphagia, but sometimes even an enlarged heart can press on the esophagus, especially in the elderly, causing some sort of a difficulty in swallowing.
Right. Now, just to recap what Dr. Naomal Perera said, dysphagia or difficulty in swallowing can be caused within the lumen of the esophagus or the hollow part of the esophagus, or it could be something in the wall of the esophagus or something compressing it from the outside. Now, sir, in this day and age, I have to ask you this question before we move on to the esophageal cancers, because we see a population with gastritis and gastric reflux, and we hear of a certain condition with chronic reflux, the acid coming up. We have heard of this condition which changes the inside structure of the esophagus. Can you just elaborate on that for us?
Yeah, most of the problems that is associated with esophagus and most of the symptoms are related to this acid production within the stomach. We call it in lay person's term as gastritis, and the reflux, and we call it heartburns. Those are the common causes to give rise to various issues in the esophagus. And I mean, talking about cancers again, the reflux of acid and bile is one of the commonest causes to get esophageal cancer. But when this reflux occurs, now the acid, to tolerate this acidity within the stomach, there is a special lining, and but in the esophagus, that lining is totally different, because in the anatomy they think that the acid will be confined to the stomach because of the low esophageal sphincter. That is why I spoke little about the sphincter at the beginning, because this will prevent the acid getting reflux upwards. But if the mechanisms are not working properly, the acid can get reflux, and with that the inner lining, especially in the lower esophageal area, can alter and it can become more or less closer to the gastric type of epithelium, and we call it Barrett's esophagus. And the Barrett's esophagus is also a risk factor to develop esophageal cancers later on. So, I mean, overall, when you talk about the esophagus, all the problems that is associated with esophagus is due to reflux.
So, not to alarm our viewers, but if you are indeed experiencing reflux and if it is uncontrolled, if it is not being treated properly, I think this would be a good warning sign for you to get followed up by your medical practitioner, get the proper treatment and ensure that you do not undergo this chronic reflux, because like Dr. Naomal Perera said, it could be one of the risk factors which leads towards esophageal cancer. Now, talking about esophageal cancer, now we spoke about breast cancer with you earlier on Healthline, and we know that it is the most common cancer in Sri Lanka and worldwide. But when we talk about esophageal cancer, is it very common when we talk about the globe, and how does Sri Lanka compare?
Worldwide, it stands around about the 9th or the 10th leading cancers in the world, roughly about say 600,000 cases per year. But in Sri Lanka, we have seen the esophageal cancer incidence slowly rising up, and when you consider both males and females, it is the 5th commonest cancer in Sri Lanka. And among the males, it is the 3rd commonest cancer. First is oral, second is lung, and the third has become esophageal, followed with colorectals. So, the esophageal cancers is becoming popular gradually every year like, and this is more or less commonly seen among the males, about 2 to 3 times more than the females, and it is found mostly in the inner part of Sri Lanka, that is in the maybe the Tamil community in the upcountry area, or maybe not along the coastal belt. It is mainly inside the country. We have not done any sort of demographic studies to sort of identify why it is confined more towards the inner part of Sri Lanka and not to the other areas, but it is more or less found within the low socio-economic and the inner part of Sri Lanka.
Any particular reason why we think that the incidence is on the rise? Anything that we can associate it with?
So far, not a single study has been done to sort of identify why the incidence is going up. It could be either neglecting of acid reflux, because so far none of the chemicals or food items have been identified as a risk factor or a causative factor for esophageal cancers. The commonest is acid reflux, smoking, alcohol. Those are the common reasons to get a esophageal cancer.
Right. Now, before we move further, sir, I think we may have alarmed our viewers a little bit by talking about the reflux. Does it inadvertently mean that if you have reflux and if it goes on long term, that it will automatically convert into a cancer?
It is not so. The important thing is, the important message is that most of the time, many people, when they have reflux or gastritis, they tend to sort of go to a pharmacy and say, mention the symptoms and buy over the counter and certain antacids, and they go on sort of using it. Or even if they go to maybe their family doctor, and when you sort of mention about these things, and get some drugs prescribed to take it on and off whenever they get these symptoms. But the important thing is, if this symptom is going on, my recommendation is, it is always better to do a baseline study and rule out that your the esophageal epithelium is not changing to Barrett's, and especially there are no ulcerations, there are no sort of burning effects on the esophagus, and the esophagus should appear perfectly healthy even though you have symptoms of gastritis. So, if those things are not there, I think that is the main reason why, rather than I am sort of scaring the viewers off, it is very important, if you have gastric reflux, to assess it properly and see, not to sort of continue your treatment over the counter for many years without proper investigation.
Definitely. Now, even if you followed Healthline, we did a program on gastritis, and that is one thing that we reiterated time and time again, not to try and self-medicate. because that may lead towards you overlooking a underlying condition which can be nipped in the bud, but which may turn into a sinister cause later on. So, now sir, we are talking about esophageal cancers, and we spoke about its prevalence in Sri Lanka and globally. Now, with this you spoke about certain risk factors as well. Does genetics play a role in this?
It is not so, but anyway the Barrett's esophagus you can get, there is a little bit of familial tendency to get Barrett's esophagus. I mean again I need to mention this now, viewers who will be listening to this might sort of take the message only about Barrett's, right. Now I have to sort of clear your mind as well, because Barrett's is not that common in this part of the world. It is mostly commonly seen in the western countries, fair skinned people and among the males who are over 50. Those are the people who might get Barrett's. In Sri Lanka, the Barrett's, the incidence of Barrett's is much less. So, when I sort of answer your question back about the familial tendency, it is not so. Other than for Barrett's, there is no familial tendency to get esophageal cancers.
Now, you spoke about smoking, alcohol as risk factors for esophageal carcinomas, but now what about chewing of beetle and these certain other materials that our community, especially the agricultural community or the rural communities use? Is it also, we know that it causes oral cancers, but is it a risk factor for esophageal cancer?
No, it has not been sort of clearly demonstrated that there is some association between chewing of beetle and esophageal cancers, because most of the people who chew beetle, they rather than they swallow the carcinogenic liquids, they spit it out. So they don't swallow it. So and also the studies which have done to sort of see whether there is a link between the esophageal cancers and beetle chewing, they have not found any association.
Right. So now a person may present to you with difficulty in swallowing, and if one of our viewers are indeed having difficulty in swallowing, they might get alarmed thinking that this might be cancer in the esophagus. But what are the other symptoms that may be involved with this condition, sir?
Yeah, the important thing is the dysphagia. It should start with the solids first, and gradually with time you will realize even they find it very difficult to swallow liquids. Now, the important thing is the diameter of the esophagus is roughly about 2 centimeters. Now, if this get narrowed up to about 1.3 centimeters, you will not have any symptoms. So, that means 7 millimeters of your lumen have been taken over by the tumor. So, it is a fairly big tumor then, 7 millimeters, right. So, then only you will start getting the symptoms of dysphagia. So, that is what I said at the beginning, whenever you have long term reflux, it is better to have a baseline investigation done, because most of the symptoms that you get it in with esophageal cancers are little late in the disease process. So, the first is difficulty in swallowing, and with that you will realize that there is sometimes a little bit of chest pain, especially when the food goes in, or there will be some reflux and burning sensation. So, those are the commonest symptoms that you will see at the beginning. But if this goes on, gradually you will realize the amount of food they have been taking, they reduce it, with every mouth they have to take some water to sort of push the food down, and gradually they will start losing their weight, and say if they start losing about say 4-5 kilos within a matter of say 2-3 months, that is a very significant sign. And later on, I mean, if this goes on for without any sort of investigation, there could be little bit of bleeding from the tumor. Then of course, they will not vomit, rather than vomit, because there is a obstruction. Usually the vomiting, if a patient vomits, it has to start from the stomach. The stomach should contract and push the food up. So here the block is up. So it is, rather than vomiting, they cannot swallow, they stop it. So you don't get much vomiting, but if there is little bit of bleeding, it can go down the passage and your stool color might change and it can become sort of dark blackish stools. So those are the common symptoms and signs of esophageal cancers.
Definitely. Now, if you are experiencing even a little bit of difficulty in swallowing, not to alarm everyone, because not every case of difficulty in swallowing turns out to be esophageal cancer, but definitely it is worthwhile to go and assess it by a properly qualified medical practitioner. Now sir, you spoke about patients with reflux and how they should get followed up to make sure that their esophageal lining is in order. So, what would you suggest that they do and how often?
I would suggest that if the symptoms goes on for more than 6 months, it is always better to sort of do the endoscopy. We call it upper GI endoscopy, that is a upper gastrointestinal endoscopy, and it is done as a OPD procedure. You need to sort of go there fasting for 6 hours with a, I mean, after making an appointment. You cannot just walk in like sort of giving a blood sample. So you have to make a prior appointment with the surgeon or the gastroenterologist, and it is done without any form of anesthesia or sedation. We use a separate thing called a spray, a lignocaine spray, that is for local anesthetic, to get some local anesthetic effect. We spray the throat and the oral cavity area where you will not sort of have the gag reflex or the reflex that you feel like vomiting when the tube is passed in. So that reflex goes off, but you will feel the tube just passing through as you are putting a finger inside without the gag reflex, and we just push the tube in, and once it is in the stomach, we bloat the stomach, then you will feel the stomach and the abdomen getting bloated up. But when the endoscopists take the tube out, they will aspirate or suck out all the gas out, and the whole procedure will last for about say 5 to 10 minutes, including if there is any suspicious area in taking a biopsy as well.
That is some worthwhile advice from Dr. Naomal Perera. If you are having these symptoms for more than 6 months, it is definitely worthwhile to get upper GI endoscopy done, just to clear any doubts that everything is in order, at least there is no sinister cause behind your symptoms. Now, moving back to the cancer, say esophageal cancer, a patient presenting with the symptom profile we spoke about presents to you. How would you go about in your approach to diagnose this patient and then move on to which sort of treatment modality you would choose?
Yeah, the first thing is we cannot sort of diagnose by sort of examining, palpating, pressing, unless if the patient comes in a very sort of advanced stage disease where it has spread to the nodes around the neck area. So we cannot sort of feel the tumor. So only way we can diagnose is by passing the scope. So we have to do the endoscopy first. When we pass the endoscope, if there is any suspicious areas, if there is a growth, we take biopsies, and we always try to sort of, if there is a growth, we try to bypass the growth, in the sense push the scope through the tumor and go to the stomach as well, because anyway the endoscope, the size is about a centimeter. So even at the beginning when they start getting symptoms, when it is about 7 millimeters gone and there is still about another 1.5 to 1.7 centimeters remaining for us to pass the scope, that is the ideal time to pick a esophageal cancer. Unfortunately, most of the patients in the world as well as in Sri Lanka, they present at very late stages. I would say about 70 to 80%. In Sri Lanka, I would say even 90% of patients, when they present with dysphagia, they are very late, they are at an advanced stage, because they have been just ignoring, they think that dysphagia might go off, they try to sort of push food with water, they try to sort of blend the food and sort of stop or avoid taking heavy or solid food material. So they try all sorts of things without just sort of getting it investigated.
Now, when we talk about cancer, always early detection is key, because if we identify it early, the outcomes, the possible treatment modalities, all the options are available for you with the advancement of technology and with a wide variety of specialists involved. So, always like we reiterate, early detection is key. So, do not ignore if you are having some symptoms, always better to get it sorted out and your doubts cleared with a properly qualified doctor. Now, you said we will be taking a biopsy with the scope, so once we pass the scope, if you see any suspicious areas. Now, like I said, we have some doctors and medical students following our program as well. So, just for their academic interest and for anyone else who would like to know, once we take the biopsy, we know that there are several types of esophageal cancer. So, what are these types?
Yeah, now at the beginning I said this is a muscular tube, and it starts from 15 centimeters from the front teeth, and it is only about 25 centimeters long. So that is 15 and 25 by the length of 40 centimeters, it becomes a stomach. So within this 25 centimeters, the top part, it is very interesting to sort of realize that our alimentary tract is adapted in such a way where the top part from the mouth onwards towards the top part of the esophagus, almost 2/3 of the esophagus is lined by a epithelium called squamous. Squamous epithelium is the epithelium that is found in the skin. It is little different. That is to sort of handle all wear and tear of when you sort of swallow solid food. It can shed, the epithelium can shed, but at the same time from the basal layer it can sort of regenerate the epithelium. So the top part is like the skin, it is a squamous epithelium which is covering the 2/3 of this tube. The bottom part is, it becomes so much secretory, it produces a lot of secretion, so the food will become little softer, and with that it will be pushed into the stomach. So the bottom part is, the epithelium is called the column epitheliums. So these two different epithelium give rise to two different cancers. In the top part we call it squamous cell carcinomas, the secretory part we call it adenocarcinomas. Now when you consider the 25 centimeter tube, I mean in a not anatomical way, we just divide into 3 depending on the incidence wise, the upper 1/3, middle 1/3 and the lower 1/3. And in Sri Lanka, the almost 60% of the tumors are found in the middle 1/3. So those are all squamous cell carcinomas. Then about 30% is found at the lower part, those are adenocarcinomas. And the top one, the upper 1/3, again it is squamous, because I said the top part is squamous, and it is about 15% of the cancers are found in the top. And mind you, I mean I have to mention this, the top ones are commonly found among the females.
Is there any particular reason for that, sir?
There is no real apparent reason where we can sort of a scientific reason where we can give, but it is associated. There are a couple of scientists who have found this, we call it Plummer-Wilson syndrome, where it is associated with iron deficiency anemia, that is lack of blood, hemoglobin in your system, and these type of cancers are associated with that, and that was found by Plummer-Wilson, and that is known as Plummer-Wilson syndrome, where females tend to get upper esophageal cancers, and those are all squamous. So as I said, the upper is squamous, middle is squamous, and the bottom is adenocarcinomas.
So for the purpose of outcome and treatment, is there any difference of these squamous cell carcinomas and adenocarcinomas, whether it's the top part, middle part or lower part? Does the outcome differ?
The outcome actually depends on the severity of its spread, and whether it is sort of spread to distant organs or whether it is locally advanced. That is the main factor which limit the prognosis, or where we can say it is curable or not. But when you consider squamous ones, those are more radiosensitive, in the sense we can treat with radiation, and it is sensitive to radiation more than the adenos. For adenocarcinoma, this is a general rule. For adenocarcinomas, more or less chemotherapy will work better. Right. So those are the differences, but the important thing is how big the tumor is, how far it has spread, and whether it is locally, because there are a lot of structures. I said this mediastinum, there are a lot of structures which are very, very important. The trachea, the bronchi divides, then we have the aorta, and we have the pericardium. On the sides we have the lung. Pericardium is a sort of a wall which covers the heart. So if you sort of it can sort of penetrate the pericardium, or it can penetrate into the lungs on the sides. So those are very, very important to understand whether it has spread or whether it is confined to the esophagus, and whether it is early, to decide how treatable the patient is.
Right. So you spoke of the local spread, sir. What are the other sites, the distant spread, where can this cancer spread to?
The esophageal cancers commonly spread to the nodes. Those are the lymph nodes. Those are found again in the mediastina. But if it is it's a low esophageal cancer, then it can go into the nodes which are found around the stomach as well. And also sometimes the nodes can spread even up to the neck nodes as well. That is the commonest one. In addition to that, through the bloodstream it can spread to the lungs. That is also common. then the bones, liver and the brain. Those things are not really common because before it spreads to the brain, they will have lot of symptoms and they might sort of die of the local disease because there is no space for the tumor to sort of expand or spread.
Right. So, now a patient comes to you with these symptoms, you have done endoscopy, taken a biopsy and found which type, whether it is a squamous or the adeno, and which part of the esophagus this cancer is. Now, to further assess, now we spoke about spread, are there any other investigations that you would like to do on these patients to assess where this has spread or whether it is confined to the esophagus itself?
The most important thing or commonly done investigation is a CT scan. We can do MRIs as well, but the CT scan gives fairly good reports and good images. In the CT scan, there are a few things that we look into. One is whether the tumor has spread beyond the wall and gone into close by structures, especially the bronchi or maybe the lungs and things like that, and whether there are nodes around that, and whether it has gone to the lungs as through bloodstream as distant deposits and to the liver. So, we do a CT scan starting from the neck, chest and abdomen. Abdomen, the upper part is enough. We do the neck as well because sometimes in advanced cases from the nodal spread it can go to the mediastinal nodes, from there it can go up to the neck nodes. So, if it has gone up to the neck nodes, that means it is inoperable, we can discuss it some more. So, because of that we have to sort of do a CT scan starting from the neck level up to the upper abdomen.
Now, if it is only confined to the esophagus itself, as an oncological surgeon, do you offer them surgery, sir?
Surgery is the best.
Right.
Surgery is the best option.
And for locally, if we can discuss the treatment modalities, let us talk about the locally advanced tumors and whether there is any distant spread. What are the other types of treatment modalities that you can offer for these patients?
Yeah, the treatment modalities, there are only two more that we can offer, that is chemotherapy and radiotherapy. Now, when we consider the surgery is not an easy surgery. It needs a lot of training and only specialized surgeons will handle these type of cases. Basically, there are couple of issues. One thing is we try to do or remove the esophagus without opening the chest, because if you open the chest there is extra morbidity. So, because of that we can do either transhiatal, that is we open the abdomen, from there we sort of blindly using our hand we sort of try to dissect the entire esophagus from the abdomen up to the neck level, and also make a small cut at the neck level and do the same thing. Now, once we remove the esophagus, we need another tube to replace that area. So, either we have to use the stomach, which is something like a balloon. So, we have to shape it up to make it a tube and push the tube from bottom, the stomach as a tube up to the neck and sort of connect it there. Or if the stomach cannot be used, especially if the tumor is at the lower end, then of course there is a possibility that it might be sort of invading into the stomach. So, we will not have much length of stomach to be pulled up. So, in that case we can either use the small intestines or sometimes even the large intestine as a conduit to sort of connect the stomach into the neck. Now, this type of surgery is not an easy task. It is a very, very major complex surgery. So, if we cannot achieve some good cure rates, then of course not worth doing a surgery like this. So, that is why we need to assess and see whether this is locally advanced or curable, and if it is curable, that means stage 1 and 2, that means it is confined to the esophagus, there are no nodes, not in the lungs, not in the liver. So, we know it is only in the esophagus. So, we know that if we remove the esophagus, we can cure the patient. So, in those instances surgery is the best option and the cure rates are high.
So, that is a curative procedure rather than a palliative one?
Yeah, it is a curative procedure. Sometimes if the tumor is little big, we might offer neoadjuvant chemotherapy, that is we call it neoadjuvant chemotherapy, when we give chemotherapy before surgery. We sandwich the surgery in between, we give chemotherapy, do surgery and give chemotherapy again. So, that is another concept of reducing the size of the tumor. So, once we give chemotherapy at the beginning, about 3 doses, then it shrinks a little more, then it becomes very much operable, then we can proceed with chemotherapy. Even that is, the cure rates are very, very high.
Right. So, if a patient has advanced cancer, you spoke about chemotherapy, radiotherapy. So, that is used as a palliative measure rather than a curative one, is it?
It is a palliative measure, but before that there are few things that we need to attain. That is, now the patient cannot eat.
Yes.
Patient has lost weight and patient is anorexic, not eating. We have to identify whether patient can tolerate chemotherapy. So, we have to give good nourishing food to this patient. So, we have to somehow attend to this obstruction first before we send the patient for chemotherapy. Either we have to sort of dilate the block and put a stent. These could be temporary stents or permanent stents. We have to put a stent. There are instances where we will not be able to put a stent even because the tumors are so large and it is very tight, and it is the patients are very weak and moribund, and if you try to sort of do these type of things, it might affect his hemodynamics, and so because of that we will not be able to do it. Then of course we have to either, if we can pass the scope through, if possible, we can go to the stomach, and there is an endoscopic procedure where we can sort of put a tube directly through the endoscope into the stomach without opening up. We call it the PEG
tubes.
So, we can sort of use a PEG tube, or else then of course otherwise we have to open the abdomen and open the stomach and put a tube for feeding purposes.
Just to optimize the patient.
Optimize the patient. This is the first thing that we may have to palliate, his obstruction. Next we can sort of palliate, try to sort of reduce this tumor by giving chemotherapy and radiation. Sometimes it might work. If it happens, then of course we might be able to sort of take the tubes off, or else we can leave it, whatever. But we are not talking about a proper cure. We are just palliating or controlling the disease.
Controlling and improving the quality
of life.
Now when we talk about cancers, we talk about these 5-year survival rates. When it comes to esophageal cancers, I'm sure it may differ from depending on the amount of spread, but when we talk about esophageal cancer, what is the 5-year survival rate?
5-year survival rate, as I said, in Sri Lanka, it is poor because of late presentation. There is nothing else, no other reason. I would say stage 1 and 2, when it is confined to the esophagus, which has not been spread to the nose or to the lung, I would say about 85% stage 1, about 65% survival rates in stage 2. There is a good survival rate for esophageal cancers. But if it goes to stage 3 and 4, then of course it drastically dropped down to about 25% to 15%. Right. If it is stage 4, 15%, 5-year survival. Very rarely a person might go beyond 6 years or so, I mean, very rare. So, it is usually say 15% might survive up to 5 years.
Right. So, if let us say a stage 1 or 2 patient comes to you and you have performed the surgery and we have taken out the entire tumor, is there a chance that it may recur again?
It is possible, always possible, especially if there is some sort of spillage of tumor cells, or maybe although we take the nodes, there could be 1 or 2 cells stuck in those lymphatics. That is always possible. That is why we always sort of support our treatment with some sort of a radiation, even to sort of destroy the remaining tumor cells. The most important thing is that, and the other thing is there is one more thing that we have not discussed, that is the strictures.
Right.
Now, we bring a different conduit or a different tube and connect it to the top part of the esophagus or the pharyngeal esophageal part. So, it is an end-to-end sort of connection, so, and you can get a scar like a ring.
Right.
All the scars which are shape of a ring, with time the scars contract. So, when it keep on contracting, it might get narrower and narrower,
and that might cause an obstruction.
That might cause an obstruction, and it becomes dysphagia again.
Right. So, is there any preventive measure for that?
Yeah, I mean, not that we can prevent, but we can treat. That is, we regularly dilate the strictures. There are different good way of dilating nowadays, not like the passing of various solid rods. Now we have the balloon dilators. So, or in case if it is very, very severe, we can sort of attend to it surgically as well. But those things we can reverse those.
So, even if a patient has been cured, I guess regular follow-up is always pertinent with the oncological surgeon, I believe.
Yes, it is very, very important. The follow-up is very, very important for every patient. I don't think that they should stop even at 5 years. they should go forever.
Definitely. Now, with our time constraints, sir, we are coming towards the end of this program, but before we wind up, what would be your advice? Now, we know esophageal cancer is not as common as the other cancers, but like you said, the incidence is increasing. So, before we wind up, what is your advice to our viewers?
To give this advice, I will take me as an example. I would normally say that for any person who is having dyspeptic symptoms or gastritis or reflux, to do endoscopy. That is my takeaway message for everyone. And me as an example, I have done 2 endoscopies just to rule out that I do not have anything in the upper esophagus or the stomach.
Definitely. Now, with our current day-to-day lifestyles, the stressful lifestyles, our dietary habits, the gastritis, the reflux is very, very common. So, if you are having it long term, always better not to self-medicate, to be followed up by a qualified doctor, and to make sure that you get this endoscopy done, just to be sure that there is no sinister cause, there are no sinister changes in your system. So, with that message, we thank Dr. Naomal Perera very much. Thank you once again for coming here on Healthline. So, it has been a pleasure to have you. And until we meet you again next week, I take your leave from this edition of Healthline. So, wishing all our viewers the best of health, and once again I want to reiterate, we are not safe from COVID yet. Continue practicing your social distancing, wear your face mask. If you haven't gotten your booster, definitely get it as soon as possible. So, with that message, I take your leave until we meet you again next week with your weekly dose of wellness. This is me, Dr. Dilshan Fernando, wishing all our viewers Aibowan.